Bueno, pues más que nada vamos a darle continuidad al programa y bueno, pues ha sido un programa que, como ustedes lo pueden ver, está lleno de información y ojalá que pues, esté haciendo mucho de provecho. Y bueno, esta primera sección, bueno, vamos a tener el cierre, ¿verdad? Con un ponente que, bueno, habla por sí mismo. Dr. Joel Kopple es pues, nefrólogo, él formado en la Universidad de Northwestern en Chicago, y bueno, está desde hace muchísimos años de nefrólogo, inicialmente en la Administración de Veteranos en Washington, Los Ángeles, California, y desde aproximadamente 1970 se convierte en el jefe del Hospital de Nefrología en Harvard UCLA Medical Center en Torrance, California. Y pues vaya, ¿verdad? Que si él tiene todo ese currículum, todo ese bagaje científico y es realmente un experto en metabolismo y nutrición. Y bueno, hace tan solo un par de años acaba de sacar la última edición, un libro que ustedes, a lo mejor muchos de ustedes la conocen, que es el libro, ¿verdad?, de nutrición en enfermedad renal en inglés, y bueno, realmente es una delicia. Pero él no nomás, insisto, tiene esa situación, ¿verdad?, personal, como un buen hombre de ciencia, sino que además conviene situación, como ustedes lo pueden testiguar, es sencillo y es además una buena noticia, quiere mucho a México y la mejor muestra que está aquí con nosotros y lo que él ha aportado aquí al programa. Y bueno, su área de interés, como le hemos dicho, es precisamente metabolismo y nutrición. Y bueno, he preparado esta plática y la del día de mañana, realmente temas, ¿verdad?, que van a redondear todo lo que hemos aprendido del grupo aquí del doctor Cueto, y felicidades por estas pláticas. Un tema, ¿verdad?, que también nos va a actualizar justamente cuál es el estado actual de la situación del manejo nutricional y metabólico en esta área tan fascinante que tenemos en los últimos años, ¿verdad?, de nuevos conocimientos, nuevas drogas que pues están cambiando en el día a día, y cómo van a impactar esto en el manejo de estos pacientes, sobre todo en algo, ¿verdad?, que tenemos que es bien grave y que lo enfrentamos mucho aquí en México, que es la situación de desnutrición, y entonces nos va a marcar mucho las guías actuales, insisto, para el manejo de estos pacientes. Entonces, sin más, Joe, please, Dr. Kopple.
That's right. That's good. I'll take it off if I need it. In fact, I will take it off. Okay, great. Okay, well, thank you very much, Dr. Montillon. It's a great, more than a great pleasure, it's also a great honor to be here. And which way? I go this way. How do I turn this thing forward? So I press this. Okay, I would just like to say a few words about my friend and colleague, Dr. Montillon. He keeps saying that I've had an important impact on the creation of your transplant center, and I must disagree. It is true I met with the hospital director and I also sent a letter, but I only stated what I had seen in Dr. Montillon, a man who is very humble, but possessed with enormous vision and energy, and who worked so hard to create the center that you have, and which you all are honoring today. And I must say that with my most sincere respect and congratulations, not just to Dr. Montillon, but to all of you for all the hard work that you've done, your vision, your dedication, the frustrations that you've endured, the brilliant diagnosis and medical therapy that you have conveyed. Thank you, gracias. And I think what we're having today and tomorrow, and with transplantation going on all over Mexico, is the result of your hard work and labor. And if I played an extremely tiny part in this, I'm grateful for that. But I did not do the work. It was not my vision. It was yours. So congratulations. Now, to continue with my talk, I'm having trouble with this. Maybe somebody can help me. Fine. Can I just say next slide? Okay. I'm going to cover a large number of topics today, and I'll cover most of them rather briefly. Do low-protein diets delay the need for chronic dialysis? The importance of treating obesity, the importance of the microbiome, the SONG initiative. When does protein energy wasting occur in CKD patients? The importance of treating protein energy wasting. And something which is unique to Mexico, your CEAN centers. Look, I can't do this, so I'm going to say next slide. Next slide, please. Now, let's start with, do low-protein diets retard the loss of GFR in CKD patients? Next slide. There are essentially two types of low-protein diets for CKD patients. One, it provides 0.6 to 0.8 grams of protein, of which roughly 50% is high biological value. And for advanced CKD patients, 0.6 gram of protein per kilogram per day. And then there's the supplemented very low protein diets providing 0.3 to 0.4 grams of protein per kilogram per day plus 7 to 15 grams of the 9 essential amino acids, or a mixture of the 4 essential amino acids plus keto acid or hydroxy acid analogs of the other 5 essential amino acids. Next slide. Now, I'm just going to show 2 slides on this. The first is by Bertrand Kasinsky, where he looked at the actual GFR measurements and found that there was a significant slowing in the rate of loss of GFR, but it was only 0.53 milliliters per minute per year. However, this study included the study by Dollard et al., which was largely negative, and the reason it was negative was because they ran out of money, and they had to let all of the nutritionistas go. So they were just following the patients with no nutritional management, and in my opinion, it was unfair to include those patients in Kasinsky's meta-analysis. Next slide. The other study I referred to, next slide please. No, go back please. Go back one more. One more again. Okay, go forward. Next slide. Next slide. Next slide again. Now, then there is a study by Denis Fouque from France, and he showed a highly statistically significant reduction in the looking for the here in the time, the length of time patients were delayed in their onset of going on to dialysis therapy. He did not look at change in GFR. He looked at time to starting dialysis or kidney transplant, and he found a highly statistically significant reduction of about 31%. Now, the difference is he didn't look at change in kidney function. He looked at when the doctor decided the patient needed to go on dialysis. And next slide. I think these data are not in conflict. I think what these studies show is a very small effect on slowing of GFR, go back, and a very much larger effect in delaying the start because the patients, what do I press here? This. Because the patients were less uremic. And I think this is the point. that low protein diets, particularly because many people do not adhere closely to them, may not delay or slow the rate of loss of kidney function in a dramatic sense, but they do delay and reduce the degree of uremic toxicity and the development of protein energy wasting, thereby allowing the patient to remain off dialysis for a longer period of time. Next slide, please. Now, so low protein diets do have a fun effect in slowing progression. However, independent of this effect, a low protein diet may enable advanced CKD patients to safely delay the commencement of renal replacement therapy, independent of whether these diets slow the rate of progression of kidney failure. Next slide. Now, my proposal is that for patients with stage 3 or 3B CKD or CKD 4 or 5, I would recommend a 0.6 gram per kilogram protein diet or 0.3 to 0.4 gram protein per kilogram per day plus 0.3 grams of a keto acid essential amino acid supplement. Explain to the patients that this diet is nutritious, it will reduce generation of uremic toxicities. It is likely, but not proven, that it will delay or may slow the progression of loss of GFR. Monitor the dietary energy and protein intake and the body weight. If calorie intake is not adequate, increase dietary protein intake progressively up to, but no more than 0.8 gram per kilogram per day until energy intake becomes adequate. Next slide. For non-diabetic patients who are greater than 70 years of age and with a GFR estimated for the mean of the creatinine urea clearances, a mean GFR of 5 to 7 cc per minute, Brunori conducted a study and was able to demonstrate that he was able to delay the onset of chronic dialysis therapy with these supplemented low protein diets by an average of 10 or a median of 10.7 months. That's almost 1 year. He was able to postpone people from going on dialysis therapy. Now, if you consider that the average lifespan of a new onset chronic dialysis patient is only about 5 years, this is an enormous savings. Eventually, 71% of the supplement very low protein diet patients started chronic dialysis therapy 6 to 20 months later because of either fluid overload or hyperkalemia. Next slide. This slide shows the data in the upper panel. Panel A is the difference between starting dialysis according to the people who follow the protocol. People who were assigned to the protocol. And panel B was actually the people who follow the low protein diet versus going on dialysis. And you can see there's a substantial difference in survival of the patients, that the patients who went on the supplemented very low protein diet and they were randomized to this diet actually had significantly greater survival. If they were just assigned to to diet versus dialysis, and particularly if they actually followed the supplemented low protein diet. So it improved actually survival as well as delaying the onset of dialysis therapy. Next slide. Now, there are also many people who are combining now low protein diets with infrequent dialysis as a patient's GFR falls. And this slide describes this in 4 different individuals, individual researchers. I'd like to go to the next slide, which shows the data in some difference from the last study, that by Korea and co-workers, who combined patients either with a combined very low protein diet plus infrequent dialysis in 38 patients, or and compared them to hemodialysis patients 3 times per week, a total of 30 patients. And you can see the broken line The broken line are the patients who were on the dialysis. The solid line is the people assigned to the low-protein diet with dialysis only once weekly. And you can see, as you might predict, that the urine output and hence the GFR fell dramatically more in the patients who were put on dialysis as compared to the patients following the low-protein diet. Serum albumin was actually significantly greater in the diet patients as compared to, and infrequent dialysis as compared to 3 times per weekly dialysis. Beta-2 microglobulin, unfortunately, was a bit higher, but significantly higher in the infrequent dialysis patients as compared to 3 times per week dialysis. And the last slide shows, I think that's proteinuria, which was lower in the infrequent dialysis patients as compared to the 3 times per week dialysis. Next slide. So these studies indicate that the use of very low protein diets and by itself with infrequent dialysis can be used to safely delay the onset of dialysis therapy and to start people on dialysis in a slower fashion. The patient is able to get used to the concept of renal replacement therapy. And I think these are types of treatment that need to be explored and utilized more frequently. Now I'd like to turn to the issue of obesity. As we know, it's very common. We know that obesity increases the risk of both diabetes mellitus type 2 and hypertension, the 2 most common causes of end-stage kidney disease worldwide. Obesity is associated with more rapid progression of many kidney diseases. Until recently, obesity has been very difficult to treat, and until now, it is rare for an obese patient to lose much weight and to maintain that weight loss. I would say that obesity, up until recently, has been essentially an incurable disease. Next slide. This is particularly relevant to Mexico because Mexico may well be the country with the highest prevalence of obesity in the world. In this slide, it shows the prevalence of obesity among upper middle income adults 20 years of age or greater in Mexico as determined in the year 2022. 41% of men were overweight, that means BMI 25 to 29.9, and 32% of men were actually obese, and that means BMI of 30 kilogram per meter squared or greater. Combined, this comes to 73.5%, more than 3/4 of men greater than 20 years of age or greater were overweight or obese. In women, it was 35.8% and 41%, or a total of essentially 77%. Well over 3/4 of women obese. Next slide. Now, we know that bariatric surgery will reduce obesity in some patients, but if you look at the long-term data, the 10 to 15-year follow-up data, at least with the safest type of bariatric surgery where they create a gastric sleeve, the average weight loss is only something like 5 or 8 kilos, and these are people who may be 30, 40 kilograms overweight. With the higher risk type of obesity, which has many complications, the weight loss is somewhat greater, but patients still mostly remain obese. Now recently these 2 drugs have become available. One is tirzepatide, made by Eli Lilly, which is a dual glucose-dependent insulotropic polypeptide and glucagon-like peptide receptor agonist. And the second is semaglutide, made by Novartis in Denmark. And this is simply a GLP-1 receptor agonist. These compounds not only reduce appetite, but they delay gastric motility, and perhaps most importantly, they are anti-inflammatory. They are by far the most effective agents, possibly more than the safer types of bariatric surgery, at reducing body fat and also decreasing the rate of progressive kidney failure in CKD patients and the incidence of adverse cardiovascular events such as heart attacks and cardiac mortality. It turns out that when you compare the same degree of weight loss with bariatric surgery versus these insulinotropic receptor agonists, the same degree of weight loss, and these are the only two types of treatment that will effectively cause obesity, a reduction in obesity, that the clinical improvement with the hormonal agonist is vastly greater. And this has now been shown in large-scale clinical trials carried out over a number of years, that cardiovascular mortality, progression of GFR loss is much more reduced for the same degree of weight loss with these obesity drugs as compared to bariatric surgery. And the reason is thought to be because of the anti-inflammatory and antioxidant effects. It is interesting that today, worldwide, the amount of money which is paid for these drugs by insurance companies or patients runs to about $100 billion. It's incredible. The cost of these drugs is going to fall dramatically, particularly when they come off of patent, which unfortunately will not be for several years. But I think these drugs are game changers. And I think getting back to both with Dr. Rojas Campos, his paper, and the paper on family medicine that was presented by Dr. Hector Martinez, I hope I'm pronouncing your names correctly, that I think these drugs are going to markedly enhance the ability of us to control obesity and adverse nutritional effects of drugs. Incidentally, tirzepatide and semaglutide preliminary data also indicate that they reduce the craving for alcohol in alcoholics. These drugs really, so far, have been studied now for several years in multiple clinical trials, are really game changers. I suspect that unless some adverse effects develop that we've not seen yet, that these drugs will change the whole character of the management of chronic kidney disease. Now, there are some major problems. It turns out that about 20 to 30% of the weight loss with these medicines is in muscle mass. And this is a challenge for the dietitian, and also, I think, a challenge for the exercise physiologist. And it is my argument that dietitians should also be trained in exercise physiology. And I think you guys should be doing both dietetic management, but also exercise training, because I think these two go hand in hand. And it's better, in my opinion, for a number of reasons, that they be done by the same expert who has access to the patient. Next, okay, this is the next slide. Briefly, the microbiome. We know that there are about 30 to 40 trillion cells in adult humans. There is vastly greater amount of microbial cells living in or on the human body. Most of these microbes live in the gut, but they are also present on the mouth, vagina, auditory canal, skin, and other surfaces. In humans, there are roughly 100 or more times greater genes carried in our bodies by the gut microbiome than in the entire human genome. There are about 300 trillion microbes that each of us are carrying around. we could be viewed as nothing more than carrying vessels for microbial organisms. At least that's the way that a virus would look at us. Now, most of these microbes, interestingly, cannot be cultured by current techniques, and they're identified mainly by their DNA or RNA. The gut microbiome has the three domains of life: archaea, eubacteria, and eukaryocytes. Next slide, please. Several factors involving the diseased kidney and the gut predispose to increased concentrations of potentially toxic and nephrotoxic compounds in advanced CKD. The microbiota in the gut becomes altered in kidney failure and may synthesize increased amounts of different types of compounds. Blood levels of some of these compounds increase due in part to reduced excretion by the kidney and probably increased synthesis. These newly formed metabolites may be absorbed in the accumulate due to impaired renal excretion. Next slide. And they can be toxic. Next slide. Next slide after this. And this slide shows the results of three of these. One of these is the generation of trimethylmethylamine and trimethylmethylamine oxide from dietary carnitine and choline. Another is the generation of pericrasal sulfate and pericrasal glucuronide from dietary tyrosine. And finally, there's a generation of indoxyl sulfate, indoxyl-3 aldehyde from dietary tryptophan. In each of these cases, the production is because of the altered gut microbiome, and the blood levels in uremia are increased because of impaired renal excretion as well as increased synthesis. And these compounds are nephrotoxic. Next slide. I'd like to briefly switch now to another movement which is taking place, and which I think is also relevant to Dr. Martina's presentation, and it's referred to as the SONG initiative. And SONG stands for Standard Outcomes in Nephrology. And this is a movement which is gaining in popularity in the United States and Europe, in which research and patient care is designed along shared goals of the patients, the caregivers of the patients personal caregivers, clinicians, researchers, policymakers, and relevant stakeholders. What's different about this is, unlike when I was in my training and a young doctor, the focus now is really on the patient and what the patient needs and how the patient experiences his or her disease and how the patient experiences the treatment for his or her disease. The importance of SONG is that it puts the needs and interests of the patient and his or her family front and center regarding what is done to the patient. The effects of SONG on renal nutrition are uncertain. Next slide. For example, regarding renal nutrition, it is clear that many CKD and chronic dialysis patients don't like their prescribed diets. Can medicines that inhibit intestinal absorption or increase renal excretion combined with foods that are chemically modified to be tasteful and healthy, for example, they're low in various minerals and protein, higher in calorie content, enable CKD and dialysis patients to eat their prescribed diets more enjoyably? I think we're going to be seeing more of this, where we try to prescribe diets which the patients actually like, rather than just saying, look, you've got this disease, you're going to have to just grit your teeth and eat these foods which you don't like. Now, I'm not criticizing anybody for saying that, because that's where we are today. But what I'm trying to say is that I believe that the new attitudes which we see among family medicine doctors, among the primary caregivers for people with kidney disease, be they endocrinologists, diabetologists, nephrologists, that we're going to see more and more of a turn to what the patient needs to improve the quality of life of the patient. And I personally think that these changes will be wonderful as they occur. Next slide. Now, I'm going to show you some data which you're probably unaware of. And I think this opens up a whole new challenge for us in renal nutrition. The question is, next, go back, please. When in the course of progressive chronic kidney disease does protein energy wasting start to emerge? Next slide. This is a paper which I and my colleagues published over 20 years ago, 25 years ago, in which we examined the relationship between true GFR. True GFR was iothalate, that's the inulin measure, clearance measurements, iothalate measurements, and protein energy wasting in 1,760 CKD patients who were undergoing screening for the MDRD study. Only 855 of these patients actually entered the study, but all of these patients were non-diabetic, and they had GFR ranges from about 55 down to about 8 or 10 cc per minute per 1.73 meters squared. And you can see how the broken line is women, the solid line is men. You can see how dietary protein intake began to fall when the GFR was about 35 to 40 cc per minute. You can see how energy intake was low even when the GFR was 55 cc's per minute. It was about 28 kilocalories per kilogram per day in men and down to about 24 in women, and how it tended to fall progressively as the GFR fell. Everybody kind of ignored these data. Next slide. But let me show you, this shows in the same patients the serum albumin, which started at normal levels, but that fell. A normal serum albumin level is generally 3.9 gram per deciliter or higher. It's not 3.5. 3.5 gram per deciliter is a low serum albumin. I assure you of that. And notice how it fell particularly in men. Look at also the fall in serum transferrin and serum total cholesterol tended to fall a bit in men, and urine, God, I'm having trouble reading this, urine creatinine decreased, but that may in part be due to reduction in meat intake. But please note how many of these patients had, even the men who had an average about 3.4, but many of half the patients had lower serum albumin levels. Next slide. Now, this is a paper that was recently published in which we looked at the relationship between changes in the estimated GFR and the changes in weight and body mass index in almost 4,000 people who were either with CKD, either in the CRIC study, that's panels A, B, C, and D, or in the ASK study, which was the study in African Americans, black people with kidney disease and hypertension. That's these two completely different sets of patients. These patients were largely of European descent or Hispanic in the CRIC study. There were blacks, but most were Hispanic or European descent, Caucasian. These patients were all 100% self-identified black people. Notice the dramatic similarity in the curves. These studies show, this is the body weight, how when if GFR reached around roughly about 32, 34 cc per minute, eGFR reached that the weight began to fall. It fell in whether you're black, white, Hispanic, and it fell reliably in three different studies involving, if you put these two together, involving over 5,000 people with chronic kidney disease. And I assure you that if you looked at these people, you could not differentiate that from the people sitting in this room, because I was a participant in the ASK study and was involved in the CRIC study as well. Next slide, please. Now, if you also look at whether this affected clinical outcome, if you take the hazard ratio as 1 for people who had less than 5% weight gain or loss, those who lost body weight had an unadjusted hazard ratio of mortality of 1.47. If you look at the adjusted rate, 1.54, they had essentially half as great a chance of mortality if they had weight loss. Weight gain, there was essentially no change. If you look at the absolute weight change, if they lost more than 1 kilogram per year, they had a hazard ratio of death adjusted of 1.46. That's the CRIC study. If we go to the ASK study, it's the same data, essentially. If they lost greater than 5% per year of their body weight, they had a hazard ratio adjusted of 1.56 of mortality. If they gained weight, they also had a hazard ratio. That was probably because these people were gaining edema. Now, I'm not showing, because of time, the data from the children, what's called the baby CRIC study. I don't know if you know that. There was also a CRIC study for children. The data are identical. The curves are indistinguishable from the curves. Go back one slide, if you would, please. They're indistinguishable from these slides in children. The same thing. Something is happening to our patients when their estimated GFR falls to about 32 cc per minute to 1.73 meters squared. They look healthy. You cannot differentiate the way they look from a normal person. I assure you of that. I've treated hundreds of these people personally. I also assure you that they feel well, but something has gone wrong with them. Next slide. And it seems they have adverse clinical effects. Next slide. Now, is this limited to America? No. Look at these. This is from South Korea. They know that's, you've heard of NHANES, the National Health and Nutrition Evaluation Survey. My nutritionist friend, she knows of that. This is a huge study that it's been going on since the early 1970s in the United States. It's asking, what are we like as Americans? Well, the KNOW study is the same thing that goes on in South Korea, that the CKD study is a study for CKD patients in about 1,834 CKD patients in South Korea. Look at their data. This shows CKD stage 1, 2, 3A, 3B, 4, and 5. This shows the number of patients of this 1,834 in each of these groups, and the estimated GFR, the percent with diabetes. Now look at the dietary protein intake. When the protein intake hits CKD4, the protein intake begins to fall at CKD4. That's a GFR of 15 to 29.9 cc per minute per 1.73 meters squared. Look at the serum albumin level, the percent with a serum albumin less than 3.8 gram per deciliter. 9.5% for stage 1, 5% stage 2, 14.4, 14.4, 14.1 for stage 3A, 3B. Look at stage 4. It's essentially doubled. People with GFR levels of 15 to 29.9 level. And look at those who have a diagnosis of protein energy wasting. 2.2% in stage 1, 4.4% in stage 2, 8.3% in 3A, 6.2% in 3B. That's, of course, 3B is estimated GFR of 30 to 44.9 cc per minute per 1.73 meters squared. And again, what happens in stage 4? It's doubled. In stage 5, again, non-dialyzed, stage 5, it's gone up to a quarter. We're seeing the same thing in these Asian patients that we found that are blacks, are whites, are Hispanics in the United States. Next slide, please. Now, this is a study carried out from Dr. Rochavarin up in Seattle, Washington, in the United States, where he examined 336 patients with CKD 1 to 4 and looked at the evidence of frailty. And please note, these the green bar are people who are frail. The red bar is intermediately frail. The blue bar is not frail. Look at, this is GFRs of greater than 60 cc per minute. It's 5.1%. This is 45 to 59, 5.1. Look what happens in 30 to 44. 30 to 44 cc per minute per 1.3 centimeters squared. It's gone up 3 times. It's 3 times higher. What is happening? There's something happening here to our patients, which nobody understands. And in stage less than 30 cc per minute, stage 4, it's 16%. Next slide. Now, just for perspective, what is the GFR? What is the serum creatinine if the GFR is 30 cc per minute, 1.7 meters squared? The average GFR in a white male from the MDR equation is 2.39. In a woman, it's 1.77, the average GFR. That's the average. Half the people have a lower serum creatinine. They might go to a family doctor, and if the doctor says, Mr. So-and-so, you have a touch of kidney disease, you ought to watch your blood pressure, watch your diet. They're already beginning to lose weight. They're on their way to frailty. They're on their way to proteinuria wasting. They're on their way to increased mortality. And if these patients, and with a GFR 40, 1.87 cc on average, and 1.39, what I'm trying to say is that I think we nephrologists and other doctors or healthcare workers who are dealing with people with CKD, we need to, in my opinion, reorient ourselves as to what our patients are undergoing, and which they themselves don't realize they're undergoing, but which ultimately is going to have adverse consequences for the quality of their life and their survival. Next slide. Why does protein N wasting occur so early in CKD? I don't know. Is it due to reduced dietary protein energy intake? Is this protein energy wasting due to increased levels of inflammation? Due to accumulation of anorexigenic, that's appetite suppressing hormones or uremic toxins? Is it due to deficiency of appetite stimulating compounds? It is my hypothesis, I have no data, but it is my hypothesis that the kidney may elaborate an appetite stimulating hormone, which is one of the reasons why we find so early in advanced kidney failure, before the SUN is very high, BUN, many people call it, why appetite is already falling. Is it because of the lack of an appetite stimulator that's normally elaborated in the kidney? This needs to be examined. If dietary protein energy are reduced at this GFR level, what causes this reduced intake? Next slide, please. Now let me go to the next to last part of my presentation. Can protein energy wasting be prevented or treated in CKD patients? Next slide. The answer is absolutely yes. There are literally, in fact we published on it. You can look at this paper if you'd like to see citations. And this is only up to 2018. The literature is filled with randomized prospective clinical trials showing that if you treat, the RPCT means randomized prospective clinical trial. This is a crossover. That if you treat them with oral nutrition supplements or intradialytic parenteral nutrition, that you can improve both nutrient intake and also evidence of protein energy wasting, such as improve serum albumin, serum proteins, total protein, serum hemoglobin, body weight, decreased fibroblast growth factor. I point out that this is table 1 continued of this paper. This is just the second part of a too big a table to put all on one slide. Next slide. So there is no question that we can improve nutritional status with nutritional support in protein energy patients who have advanced CKD or who are on dialysis. But does it make a difference in survival? Let me show you some data on this, if I may. There are retrospective studies involving hundreds of maintenance hemodialysis patients that suggest the answer is yes. There is no randomized prospective trial, but there are 4 retrospective studies which I think are very impressive. Next slide. Is it clinically important to successfully treat protein energy wasting? Will successful treatment of protein energy wasting improve clinical outcomes, or conversely, is the protein energy wasting just an epiphenomenon with superimposed diseases such as ages, dialysis treatment, and the protein energy wasting does not affect the outcome? They're dying of the underlying disease. Next slide. This is the first of these papers that was published by Glenn Chertow, who's at Stanford University. It was published in 1994. I feel badly about this paper. Glenn doesn't know this, but I was one of the reviewers. And I only tell this to my close friends. He originally submitted it to New England Journal of Medicine. I wasn't convinced, and I suggested it was not be published. He then submitted it to the AJKD, where I again was the reviewer, and I recommended it strongly for publication. In retrospect, I made a big mistake. It should have been published in New England Journal. I only tell this to my close friends, not to Glenn. And I did because it was not random. You can't do a randomized prospective trial involving thousands of people in a study like this. At least nobody's done one yet. So they took maintenance hemodialysis patients who admitted to national medical care, that's now Fresenius dialysis, and they had 1,679 patients who were treated with IDP at least once, and they compared them to 22,500 maintenance hemodialysis patients who didn't receive IDPN and were either still receiving dialysis at the end of 1991 who died during the year. And they excluded home dialysis and CPD patients. They didn't know the IDPN prescription or the duration or frequency. Next slide. Now this slide shows the odds ratio of death. And this is the serum albumin level. If the serum albumin level is 3.3 or lower, there was a highly significant, statistically significant risk of not dying if you got IDPN during the study, as compared to if you didn't. And again, what Glenn Chertow and his colleagues did was they matched these 25,000 patients as carefully as they could to the 1,679 patients that got IDPN. If your serum albumin was 3.4 or lower, you still had a lower trend, but it was no longer significant, statistically significant. Next slide. Now, after Glenn Chertow, there have been 3 other clinical trials, or there's been more of clinical trials, but some of these trials had very small numbers of people. If you look at the trials that had larger numbers of patients, for example, the Kopple trial, they found both an increased serum albumin and increased survival in those that received intradialytic parenteral nutrition. If you look at the study of Poole, they found oral nutritional supplement increased serum albumin, but they did not compare survival. The study of Laxam studied oral intradialytic supplement. They gave nutritional supplements orally, and they found increased survival. And most recently, the study of Weiner, involving 1,278 patients receiving nutritional support versus 1,278 controls. And they again received oral nutritional supplement during dialysis and again decreased mortality with nutritional support. So these studies all suffer from the fact that they're not randomized prospective controlled trials. But these investigators did their best to match. And it's interesting that there's not one study of large numbers of patients that shows that it didn't work. So, in my opinion, until we have data to the contrary, these data suggest that nutritional support of people with chronic kidney disease or end-stage kidney disease who have protein energy wasting will improve their nutritional status, and there's a likelihood that it will improve their chances of longer survival. Now, let me go to, next slide please, to the very last part of my talk, and that is trying to improve nutritional care delivery for CKD and end-stage kidney disease patients. Next slide. There's a major challenge in nutritional treatment in chronic kidney disease patients. First, there's an ignorance, a lack of enthusiasm concerning renal nutrition by many nephrologists. Second, there's a paucity of dietitians who are sophisticated in chronic kidney disease and end-stage kidney disease treatment. This is true particularly worldwide. I'll come to a slide next on this. Third is the markedly restricted time assigned to most dietitians. It's terrible. You know, the way dietitians are, I once gave a presentation to the American, it used to be called the American Dietetic Association, now it's called the American Academy of Nutrition Dietetics. And I said that we should, in the same way we have nurse practitioners, we should have dietitian practitioners. As they shot me down, but I still think it's a great idea because that puts the dietitian front and center in the care of the patients rather than in another building in the basement, which the patients are supposed to not forget to go see after they finish seeing their nurse and doctor. And the lack of enthusiasm by many dietitians and the lack of enthusiasm and commitment by many nutrition administrators. Next slide. Now, also many patients don't have the motivation, and of course they often have malaise. The dietary prescription is often restrictive of type, variety, and amounts of foods the patients desire. There's often a greater cost to healthier foods and food supplements. And there's a limited amount of time that many nephrologists will spend on talking to the patient about the importance of diet treatment. Next slide. This is a slide which we published, I guess, 2.5 years ago now. Angela Long was the first author, where we looked at data and a questionnaire that we sent to 155 countries about the nutrition practices for CKD patients. This was sent to renal centers, to dialysis centers. And one sees, if you look that, in low-income countries, this is worldwide, that that dietetic support is generally unavailable, not available, or is never available. Low and middle income, it's still, it goes from 14% low income families. It's generally available in 31% of parts of those countries, or of those countries. Among upper middle income, it goes up to 71%, and in high income, it's still only 84% of countries do people have, CKD patients have access to dietitians. And this shows, again, the same data in a different form, the availability of dietitians or renal dietitians for nutritional care of non-dialyzed CKD and chronic dialysis patients in low-income countries. Very, very uncommon for it to be available. Middle-income countries available maybe a little less than 1/5 of the time. Upper income, a little more, and high income, about a little over 70% of the time. Next slide. Now, we have a paper now with Abril who's now from Tijuana, Mexico, as the first author, a paper in press in the journal Renal Nutrition that describes these Fresenius Kabi Care CEAN centers. There are currently 7 centers in Mexico. They treat mainly CKD patients, but also some chronic dialysis and kidney transplant patients. The patients can be referred to any CEA center for nutritional care by any nephrologist in the metropolitan area. When a patient comes to the center, a renal dietitian, experienced renal dietitian, performs a nutritional, social, and pharmacological history, performs anthropometry, bioelectrical impedance, assesses hand grip strength, and looks at the patient's biochemical data. The dietitian makes a renal diagnosis and then makes a plan for personal nutritional care is formulated. Next slide. A consultation center is sent to the referring nephrologist, usually within 1 or 2 work days. The patient is counseled on his or prescribed diet. The nutritional counseling with the patient is performed monthly until dietary adherence is acceptable. Patients are then seen every 3 to 4 or 6 months, depending upon dietary adherence and the clinical outcome of the patient. The dietary adherence is assessed by 24-hour dietary records and sometimes by protein nitrogen appearance, which you'd call, I guess, PCR. Next slide. Now, there are a number of educational activities that are carried out, not just for the patient, but for their families. And you see photographs of these patient and patient family groups in one CEA center in Mexico City. Next slide. Now, attending the CEA clinics is at no cost to the patient. Now, this is a problem. If this model is to be applied widely, one needs a method for funding these centers, these clinics would have to be devised, because currently they're funded by, the sale of this keto acid supplement, and I think the funding is actually kind of shaky. So a method for funding these from the government, from hospitals, since hospitals often pay dietitian salaries anyway, the renal nutrition centers may remove, in my opinion, barriers to nephrologists from offering nutritional care. For example, like a dialysis unit. When a nephrologist has a patient with end-stage kidney failure, they'll introduce the subject, but then they send the patient, at least in the United States, to a dialysis unit. And the dialysis unit shows the patient on a TV screen videos of what dialysis is like, the different dialysis modalities, talks about diet and other types of care the patient has to take. The dialysis unit introduces the patient to dialysis care, not the nephrologist. He or she is too busy. And these CEA centers can do the same thing. And that would, in my opinion, is likely to increase the amount of nutritional therapy that CKD patients undergo. They can give the orientation, give the rationale for new treatment provided to the patient by non-physician healthcare workers in the treatment center. Next slide. So let me summarize what I've been trying to say in my presentation. Does nutritional therapy reduce or delay the need for renal replacement therapy? In my opinion, it may slow progression of kidney disease in many patients, but perhaps not greatly by itself. But will it ameliorate uremic toxicity? I think the answer there is definitely yes. Will it maintain better nutritional status? Definitely yes. May it improve the quality of life if patients can adhere? I would argue definitely. Can it reduce mortality? Nutritional therapy to reduce pregnancy wasting? Probably. Can it reduce costs of medical care? I would argue if patients ascertain there are data on this I haven't shown, I would say almost certainly. Next slide. And let me thank you very much. What is this? Oh, this is just what we discussed. Next slide. Let me thank you very much for your kind attention.
Thank you.
very nice presentation, Dr. Kopple, like always. No sé si tengan alguna pregunta o comentario. Alfonso, Dr. Cueto, ¿alguien quiere comentar?
Thanks a lot for your excellent talk, Dr. Kopple, as usual. I have a question. In some preliminary studies from our unit, we found that, particularly done by Fabiola Martinez Campo, we found that prebiotics could improve the nutritional status of patients on peritoneal dialysis. So in your opinion, is there a room for the use of prebiotics or probiotics to improve nutritional status in patients with CKD or end-stage CKD?
I think that's a very good question, and the answer is I don't know. I think some of the data, the early data, is very encouraging, but I think the large-scale randomized prospective clinical trials have not been carried out yet, and they need to be. And I'll give a note of caution if I can. The first person who I know who did this about 40 years ago. He was a visionary. He was originally from South Africa. His name was Michael Simonoff, and he passed away, unfortunately, many years ago now. He was at Jefferson Medical School in Philadelphia. And he generally only studied around 8 to 10 people, but he studied them extremely carefully. And one of the things he found was that if you're not careful with your prebiotics or probiotics, the bacteria you're given is not what you think you're given. And I looked at his data. He and I were very good friends. I looked at his data very carefully. And I think he's probably correct. So what I'm trying to say is two things. One is I think it's very exciting, pre and post probiotics. I think it's possible that they may be very valuable. As I said, we do have dysbiosis of the gut. I have no question that that is present. And maybe changing the bacterial microbiome may make a difference. My concern is that I think a lot of the people who are working in this area may not have the background or the sophistication in bacteriology to make the changes which need to be made. And finally, I think that even though I think it's very promising and very exciting, we obviously need the large-scale studies to show that it's beneficial. I hope it does, and I think there's a good chance that it will. Thank you for your attention.
Thank you.
Talking about the same, you can read yesterday a paper published in CJC talking about that issue. That nitrate intake, gut microbiome in chronic kidney disease. You know who performed this study in Brazil? Denis Fouquet.
In Brazil?
Fouquet, yeah.
Denis Fouquet.
Yeah. And then there are interesting data about that, but because, if you can give this kind of treatment, seems like you can ameliorate, the complications, especially cardiovascular problems. I think you can read this paper.
Yes.
There
are many possible positive effects of the use of this, but concretely in the case of the effect on nutritional status, it is very interesting, but I agree, there's not much data at the moment. Thanks a lot.
Thank you. I just want to also say, I think, I was talking to the young people who've got 20, 30, 40 years, 50 years of medical care to deliver ahead of them. We're in the middle of a revolution right now that in some ways is almost as great as the revolution when chronic dialysis and kidney transplantation first became available in the 1960s, wide-scale availability. And what's going on, for example, with IgA nephropathy and other types of glomerulonephritides, what's going on with obesity treatment, the current promising research with the microbiome, it's going to revolutionize nephrology. I personally think that the care of the CKD patient 20 years from now is going to be dramatically different than it is today. And I'm so excited about that. Thank you.
Kind of population, because there are kind of not very good data. One says is not involved in this catabolic state, especially in frail patients, and I will say there are very inflammatory. You know, they have IL-6, they have PCR positive. When do you think about that?
Yeah, and thank you for the question. I think the evidence is very, very strong that inflammation has very bad effects, chronic inflammation, on the outcome in many different disease states, including chronic kidney disease and end-stage kidney disease. If you want, I could show it to you in my talk tomorrow. If you want me to, I'll bring the slides. We did a study. Ken Kellentar really organized the study, in which he drew blood. Go off the edge. He was studying almost 400 chronic hemodialysis patients. I think it was around 339 was the number. And at the end of one dialysis, he had the nurses pass out a sheet of paper to each patient, and the paper had one question on it: how is your appetite? And the patients, keep it open, the patients had 5 choices. It's very good, good, fair, poor, or very poor. Nobody checked very poor, so they all checked very good, good, fair, or poor. These were all patients living at home. The patients, it turns out, all had blood drawn within several days of the questionnaire. Their serum CRP and IL-6 values were measured. When we looked at the data, it turns out that those people who checked good or very good had statistically significantly lower CRP values and IL-6 values than those who checked fair or poor. Remember, nobody checked very poor. Think about that. Nobody knew the data. The data had not been analyzed yet. And the patients just checked off something. There was no doctor. The nurse handed some to the patient handed it back, and yet the patient's values correlated with their serum CRP and IL-6 values. Moreover, when Dr. Kellentar looked at their survival 12 months later, those who checked very poor, those who checked fair or poor had higher mortality. More of those patients died, significantly more than those who checked good or very good. So that little check-off, that little mark, kind of was a prognostic factor. It helped to predict whether the patient was going to survive or not. Let me, in final response to your question, how many of you, when you see your patients, ask your patients, tell me, how is your appetite? Maybe that should be a standard part of our medical history. I think it should be. Why? Because I think appetite is part of the funnel through which all types of inflammatory and other factors, including psychosocial, affect how a patient is doing. But please remember that, as I said in the paper that I just described to you, that when we measured CRP and IL-6, that correlated with appetite, and that also correlated with 12 months survival. So yes, I think the data are pretty strong. It's important.
And taking advantage of you still, there are a new drug, casakizumab, anti-IL-6. Some promising data talking about diminish the inflammation. What do you point? I'm saying, what is do you recommend in management to diminish that inflammation? Can make a difference? You can diminish that level?
I think the data indicate it can. Incidentally, let me again go back to tirzepatide and semaglutide. It's felt that the reason these drugs cause a reduction in adverse major, it's called MACE, M-A-C-E, major adverse cardiovascular events and progression of CKD is not just because of the weight loss, it's because these agents are anti-inflammatory. And the people who are working on this, what's this woman's name, Kathleen Tuttle. She and I were discussing it. In Washington. I think she's in Washington, but she's east of Seattle. I think she's in Spokane now, but she's in Washington. But we were discussing this, and she believes that it's partly the anti-inflammatory effects, not just the weight loss. That is the reason these drugs have such beneficial effects. I think inflammation is a terrible problem among our patients. And but again, more data will help, I think, to define this. And, I always have the expression, I'm always impressed with how often my ideas turn out to be wrong. But I think in this case, I think I'm probably right.
Muchas
gracias. Muy bien, vamos a hacer un pequeño cambio ahí en el programa, debido a que ya tenemos los bocadillos allá afuera.